Hello, RDs and RDs to be. Welcome to RD Exam Ready Live. It's great to be with you for all of you students here. My name is Zach Caseberg. I'm your tutor, your coach, your guide along the path to passing the CDR exam. You know what I like to do, which is like to make you feel better about taking the CDR exam in your future as a dietitian. So if you're joining us on this session, it means you want to get a little bit better on your material for the CDR exam, and welcome. What we're going to be doing during this YouTube session today is we're going to be spending some time together to do some different types of kind of ways to learn for the exam. And what I mean by that today, normally, I love to just go ahead and throw you into some practice questions, but tonight we're going to try something just a little bit different. I'm going to give you actually a little bit of an MNT presentation. So we're going to be going through a few different MNT topics tonight. I picked about four conditions, and the reason I only picked four was because I thought we could spend some really good, intense time on these conditions. I picked them out intentionally because a lot of students do confuse them. And so I felt this was going to be a great time for us to just say, hey, let's hone in on a few MNT topics. But with that, we're going to really be covering a lot of things as we do. What we're going to do is we're going to do these four conditions. And then after each condition, we're going to be going through a clinical scenario. I'm going to give you a patient with that condition, and you're going to help apply what we just learned in those MNT steps. We're going to discuss it all together, and you're going to use that chat function to really communicate as to what you feel would be the best way to provide nutrition care to this patient. Once we wrap that up and wrap up our questions, we'll go in and hone in on a different disease topic together. As we do these, we're going to really be testing all kinds of aspects. I'm going to be testing your ability to look at anthropometrics like BMI or ideal body weight. I'm going to be looking at your interpretation of medications, labs. I'm going to be looking at your ability to look at making problem statements and doing diagnosis. So, really, we're going to connect everything together when it comes to clinical scenarios. And I think it's going to be actually a really fun session. So, thank you for being here to all the 20 RDs to be that are joining us. What I'm going to do is I'm going to start sharing my screen. Remember that as we're going through tonight, the best way that you can communicate with me is going to be using the chat. Let me know when you have questions as they come up. With that being said, get the most out of it that you're willing to in this session. Be okay taking some risks and be okay being wrong from time to time. Post questions into the chat so I can really help to shape your brain to go right down the right direction when it comes to this knowledge. And I can't put you in the right direction if I don't know which direction you're facing right now. So, really be willing to drop things into the chat, be willing to be open so that I can help you to learn these topics just a little better and get you 1 point closer to passing this thing. So let me start sharing my screen here. Give me just a moment to work the tech out. And we're going to start out with our first condition, which is going to be diverticulosis and diverticulitis. Be right back with you. All right, everyone. So hopefully you can see that screen okay that we've got in front of us here. We're going to be discussing this condition a little bit, and feel free to drop questions like I said. So here's just a nice little MNT table to give us some of the major information for diverticulosis versus diverticulitis. First off, let's describe this description or pathophysiology that I think a lot of us miss. Diverticulosis is a condition where these small pouches will form in the GI tract, typically the small intestine. Those small pouches are called diverticula. And it's really exactly what you can kind of imagine as like a small pouch that's going to be forming in that way. So if I kind of drew, what a GI tract would look like a little bit, just a little fake simple drawing, a diverticula would be a lot like looking at this thing. And then you just have this little pouch. Okay. These little pouches that form here. Now, the reason this kind of occurs is usually it's due to like pressure, people trying to strain a lot when they're trying to go to the bathroom. And a lot of the times that straining or that contraction of the muscles can cause some folding a little bit here and can cause these diverticula to form. Basically, if you have a normal GI tract or a normal functioning GI tract, you're probably not going to be developing these most of the time. Let's talk through etiology a little bit. What causes this? So, typically, it's going to be low fiber diets, aging, and genetics. Those are three major pieces that can factor into this here. If you've ever seen patients in the hospital, and let me know in the chat if you've experienced this, it's not always a specific type of patient that I feel like ends up with diverticulitis. Seems like pretty standard people a lot of the time. Sometimes they have other comorbidities, but it's not like, diabetes all the time or anything like that. It's just kind of something that happens to people and they end up hospitalized. Let me know in the chat if you agree or disagree with that. Signs and symptoms. Let's talk through this and remember, start thinking with your brain about what the implications are of these signs and symptoms. Abdominal pain, bloating, diarrhea, or constipation. So I need you to let me know, RDB. Post in the chat. How do you think abdominal pain may affect this patient's nutrition status? What would you suspect? If a patient has a condition like a GI condition like this, what would you suspect abdominal pain, and how would it affect their nutrition status if you had to guess? What do you think? Well, the things I in particular really start thinking of is just like their intake. Yeah, Stephanie, I very much agree with you there. So, just going to be affecting a lot of their intake. Low food intake to me, absolutely. That would be affected there. In general, their PO intake, food through the mouth, as you are all saying here in the chat, it's going to be affected, right? They're probably not going to be eating meals as well, eating as much as they typically do. Eating's not going to be very fun. So that's going to be the main way abdominal pain affects their nutrition status. And maybe you can think a little bit too with the bloating, of course, that's self explanatory. Diarrhea and constipation, think out of the box a little bit, already, to be that just of diarrhea, constipation, how it affects nutrition status. Constipation can make some people feel like they're really full. And so maybe they don't feel like eating or don't feel like eating the right foods they should have. Diarrhea is the same way. People sometimes, when they have excessive diarrhea, they're extremely cautious about what they eat, or they don't feel like they want to eat much of anything a lot of the time because they're afraid of their system. All of these signs and symptoms just add up to a likelihood of reduced intake, is what we're likely going to see. Very good. Now, I kind of skipped over this a minute. Diverticulitis. This is the condition that people usually get hospitalized for if when they get diagnosed. These diverticulosis, these little diverticula, these pouches, when they get inflamed, inflammation of means itis. So diverticulitis would imply inflammation of those diverticula. And that's when stuff really starts to get painful and uncomfortable. Yeah. Good. Just checking some of these answers in the chat. These are absolutely yeah, in the chat, someone mentioned not absorbing enough nutrients. That's even a great piece that I didn't mention here either, but let's say that out loud. That, of course, your absorption of nutrients, if you have a lot of inflammation in your GI tract, absolutely, it's probably going to affect and decrease your absorption of those nutrients, especially depending on where those diverticula are located. That's a great point. For nutrition therapy, this one's really fun, and I wish I could hear all of you talk to me about this. When we're in the hospital, let's all imagine we're all standing together when we're looking at this patient with diverticulitis. They're laying there and they say, I have lots of inflammation and pain with eating. What we're going to do for that patient as they lie there is they're probably going to start out NPO with bowel rest. Reduce their level of inflammation is what the medical management team is trying to do at this phase. So start NPO, chill out their intestinal tract. I don't have an amount of timing for you there, but we kind of know we would use those probably Aspen guidelines as far as when we need to start getting them nutrients and not. Transitioning them to clear liquids just to keep their system nice and easy, and then transition to a low fiber diet. And if there's anything I can emphasize to you, it's this right here. Okay. When we are in a state of diverticulitis, we focus on a low fiber diet. That's being demonstrated with the clear liquids. That's being demonstrated with the low fiber diets. Both of those fit together, as you can tell. The reason that is because fiber is probably not going to improve that inflammation at all, because the bowel is just already having so much issues. It's like the way I've always equated it, if you've heard me say it before, if I have like a big burn, let's say I have a big burn or a big wound on my arm, and I took a bunch of rocks and I just threw a bunch of rocks at my wound, right? Well, that's kind of what I think of what fiber would be like to a diverticula, is that it's like you're throwing rocks or something very like roughage onto something that's already very inflamed, and it's going to struggle to process that. Let me know if that doesn't make any sense in the chat, but that's my best analogy for it. Big piece here. Once we are in diverticulosis, a state where we're not actively in pain, we still have those diverticula present, but they're not as inflamed. When we are in that state, we want them to be on a high fiber diet or meeting at least the RDA for fiber of what, 25, 35 grams per day, right? We want them to be meeting their fiber needs. We want them to have a healthy GI tract. So we want them to have a high fiber diet. Let me know in the chat, everyone. Do you feel like you understand very well now the difference between fiber in diverticulitis and fiber in diverticulosis? Or was that something you had really established well in the beginning? What do you think? I know I've had a few students when I worked with them a little bit, they'd be like, yeah, I can't wrap my head around it. Or the patient themselves couldn't wrap their head around, like, why am I doing low fiber when my GI tract is so unhealthy, right? Good. All right. Seems like we all have a great understanding of that. I'll keep an eye out in the chat if people do have any questions just about it there. When it comes to the medications here, the common medications that were mentioned was antibiotics. Okay. So antibiotics are going to be very common. And I want you to think a little bit further here now. When a patient is on antibiotics, excuse me, we know antibiotics can have some certain side effects, right? Can you drop into the chat if you know it? What is a common side effect of antibiotics? Anti meaning against or like almost kill in this case. Biotics meaning like bacteria, right? When we put those two together, we know that a very common side effect that you're all mentioning in the chat here is diarrhea is extremely common. Well, I don't know about extremely, but very common with antibiotics. And so you've kind of like further add this together of, okay, a patient comes in with diverticulitis, they have diarrhea, possibly, or constipation. They get put on antibiotics. Antibiotics are killing all of the good bacteria. And so then they get further diarrhea. So you can add up all these points together to be like, okay, that could further exacerbate diarrhea if combined with diarrhea already. Good. And hey, good news here. No notable labs, I would say, for diverticulitis. If they did have notable labs, I think we'd be talking about like other comorbidities or other diseases, things they might be going through at the same time. Um, if they had really, really poor intake, let's say like with poor PO, I can maybe see them having like a low potassium, for instance, just because they're maybe not eating a lot of potassium rich foods. It would have to take a long time for them to get to that point. So like maybe a low K, for instance, I could possibly see there. Okay. Well, you are all very, very bright on this. So this is good. I can't wait to see what you're going to do with our clinical scenario coming up. If you have more questions, you drop them to the chat and I'll get them addressed here. But I want to let you all read through. If this feels way too small, someone let me know, but hopefully it works well enough for us here. Read this clinical scenario just for a minute. We're going to talk together about the weight, the height, the labs, and then our questions that I have for you here. Good. So, Mrs. Stevens, let's imagine her, is a 60-year-old woman. She is ripe in age. She is admitted for abdominal pain and diarrhea. She lives alone and primarily consumes refined bread products, cream of wheat, meat, and some dairy products. She has poor dentition. Mrs. Stevens was diagnosed with diverticulosis during a recent hospitalization and is found to have diverticulitis during this current admission. We look at her weight, which is 102 pounds. Height is 4 foot 11. Labs are her albumin is 4.0, hemoglobin is 12, and potassium is 3. All right. So I want to start by first just reading through the scenario itself, make sure we all understand where we're at on each of these points. So things that I would highlight: the abdominal pain, the diarrhea, of course, her being 60, lives alone. And then based on what she consumes here, what do you notice about that diet? I want to give you a couple seconds to get your brain thinking about what does refined bread products, cream of wheat, meat, and some dairy products all have in common? Well, not a lot of nutritious foods in general, other than refined bread and the meat and such. Oh, and the dairy, sure. But I would probably say that probably the biggest issue is I don't see a lot of fiber. Pretty low fiber is something that I'm noticing right here. Pretty low fiber. Yep, absolutely. She has poor dentition. Okay, think back. It's not a word you probably use a lot in your day to day, but dentition, dentist, she has poor teeth. Okay, so maybe she has, let's just say she has no teeth. Okay. Mrs. Stevens is diagnosed with diverticulosis during a recent hospitalization, is found to have diverticulitis during this current one. I feel like I've met this patient like I don't know, many, many times. It just, I can imagine her very much. I know what she looks like and how she talks and everything. So for the weight, here's the first thing I want to do. We're going to start with our step one, and I want you to conduct an assessment here, and I want you to get her BMI. Okay. So you might have already started doing that a little bit on your own. If you'd like to do it on your own, just ignore me. But I'm going to go through the steps about I would recommend doing BMI. By the way, that being said, I know there is an American version for BMI. I like to present the metric version. That's how I've always understood it. So if you prefer a different way, I defer you to that. But I just always go with what I recommend. BMI, I know, is going to be expressed in kilograms per meter squared. Okay. So the first thing I will do is convert this patient's weight to kilograms. I know that there is 2.2 pound. Okay, yes, exactly. 2.2 pounds for every 1 kilogram. So if I want to convert this to kilograms, I'm going to have to divide that by 2.2. When I do so, I end up with 46, I'll just say zero point 0.4 kilograms. Okay, and I'm walking through this just because some of us do need practice on this, so I want to make sure we all know how to do it. For the meters here, for the 4 foot 11, I'll write this out to the side. 4 foot 11 inches. Okay. I need to convert this to meters. The steps in which I'm going to do that is I'm going to first get it to total inches, right? 4 foot 11 inches. So when I look at that, it means there's, well, 12 times 4, which is 48 inches. 12 times 4, yes. Plus 11 inches, right? So it seems like she is, excuse me, 58. She is 59 inches tall. And if I look incorrect, you all will just kind of fix me there. I'm going to convert this to centimeters. There's 2.54 centimeters for every 1 inch. 59 inches times 2.54, pardon me, is going to be equal to 100 and I'm going to call it 150 centimeters. There is 100 centimeters for every 1 meter. This patient is going to be 1.5 meters tall. Okay. If that was too fast or a whole lot to go through, I can always take a step back on it. But that being said, if you just want to come back to watch this again, come back and watch it and work through it with me on the practice. So in this case, 46.4 kilograms divided by 1.5 meters squared. Puts her BMI I got 20.6. You could have gotten something just a little bit different, but I got 20.6 there. Okay. All right. So tell me, Chad, our next step here, we have this BMI. Based on her BMI, she's pretty much just within that normal BMI range, is what we're kind of seeing here. We know for older folks, we like their BMI just a little bit higher normally because there's the expectation that they could lose weight. But that being said, I don't think she's way underweight. I think she's just about normal, being 4'11" and 102 pounds. Okay. For energy, I want you to kind of toss out what you think would be your kcals per kilogram. Kcals per kilogram, what would you shout out as your kind of best option there if you had to guess there? Yeah, I'm seeing some answers in the chat that I agree with here. So I would probably say, being that she's 60 years old, pretty normal BMI, and she has a bit of inflammation with the diverticulitis. That's certainly true. But is she septic? Is she having trauma? Is she having wounds? Not really. Not like external non-healing wounds. I would probably put her in the 25 to 30 kcals per kilogram. Okay. That would probably be my go-to for her, is 25 to 30. If I went up to 35, that would be probably if she had some other comorbidity that was causing an increase in her basal metabolic rate. She's certainly having a little elevation here with with her infection she's having, but I don't think I need to get really aggressive. I would say 25 to 30 is a good reference there. Yep. Oh, nice. Good. Good. And if you want to, just to practice it a little bit, you can calculate her kcals per kilogram there. So get in the practice of that a little bit if you feel like the question does that. In that case, you would just take how many kilograms of weight she was, right, which was 46.4, and you would multiply that by 25, which would be about 1,160 kcals, and you'd go up to like 30 for 46.4, and you're looking at about 1392 kcals. So we're looking at like around that 1100 to 1400 there. Yep. Yeah. So Bree asked in the chat, for aging adults, do we not want the BMI to be close to 24? That's a true statement, Bree. You're right. We want them to have a higher BMI in that case. When I look at this patient, I'm kind of just going off of what her BMI is, and also the fact that she's pretty short in stature, just comparatively, and she's pretty low in weight. I don't know. Brie, I don't think she's underweight. I think we would love her BMI to be higher, but I don't think she's underweight necessarily as like a low BMI. But yeah, I would like her to be higher. Even despite that, though, I probably wouldn't increase her calories anymore. I would still leave her calories at 25 to 30, just because you don't want to overfeed her and further cause inflammation and infection, because overfeeding can also lead to further inflammation. So we would want to avoid that. What do you all think about protein needs? What would you clock her in at for protein? This can be a little harder. Yeah, feel free to drop in the chat what you think would just be like your best fit. Um, I would kind of start by saying, would it be 0.8 grams per kilogram? I think that would kind of be too low for Mrs. Stevens here. Zero point 0.8 is what we kind of use for the standard healthy adult, and that would feel a little low just because she does have some inflammation. I see some answers in the chat here that I totally agree with. 1, 1.2, 1 to 1.5, totally fine there. I think would be great. 1.5 might be starting to push it just depending on how inflamed she really is, or other things going on. But in general, I think 1.2 would be the number I would pick. It's great. Good. And if you feel like you don't understand why we're picking the numbers we're picking, feel free to ask in the chat. We can elaborate more upon that, as to why we're choosing the numbers we're choosing and why it's not higher, why it's not tremendously lower. We can always elaborate upon that, and it's a good discussion piece. So now for a PES statement for the patient, I don't want you to go too crazy with thinking about like intake, clinical, behavioral. What would be two PES statements that you think would fit for you? If you want, I don't want to mess up what we got going here, but if you want, you can go ahead and you could look up the diagnostic criteria. It's that chart that we all used a little bit, when we are forming our PES statements, and you can peruse on there and see which ones you think would be a good fit for you there. It's always a good thing to have in your back pocket. Mhm. Question in the chat: are you only using 1.2? I Let me correct that. So I would do 1 to 1.2. 1 to 1.2. 1.0 to 1.2 grams per kilogram. That'd be what I'd pick there. Cool. Yeah, so I asked for a full PES statement, but that's probably a lot to ask for. Has there been any problem statements or diagnosis that you've made for the patient, based on this clinical scenario here? I can kind of think of one a little bit, but I want to say, think a little bit about what we've got here. Yeah, that's my favorite one, just dropped into the chat here. This one is just like on the money. Alter GI function. This is a really great diagnostic criteria here. And to ask you all, alter GI function, I'm not going to tell you all, but I want you to ask in the chat, is that going to be intake, clinical, or behavior environmental? Which one's that going to be for alter GI function? Think about it there. Let's build up a little PES statement based on that. Altered GI function. So problem statement is done. Etiology is what is causing it, right? So the etiology in this case is related to inflamed diverticula. I'm gonna just put as evidenced by AEB there. Diagnosis of diverticulosis. Ulitis. Okay. Cool. So I think that could work as like a PES statement for this here. Yep. That's a clinical related one that you can kind of see that we're working on there. So that's going to be a clinical. Now I want you to think of an intake one. Oh, this is what I was going to get to right here, Stephanie. Yeah, so I was going to get to an intake one too. This is also one that could apply, right? So we could go with the intake as well. We always usually want to prioritize intake if that's what we can have impact on. So with this one, we could do inadequate. The inadequate intake, here's my thought. Inadequate intake, we would have to have some good evidence that she has inadequate intake. And let me ask you all, Do we have enough evidence to say that she has inadequate intake of calories? Yes or no? To me, no. I don't have how much calories she's eating in a day. So, how can I say that she has inadequate energy intake? You know, that would be one thought I would have is just, hey, do we have the evidence to do that? Could be potential for inadequate intake. Maybe that's kind of a guess a little bit, right? When we're doing that. Um, Another one that I really like is when a patient is in a state of increased stress or increased inflammation. I could do something like increased need for calories in the diet, for instance. So that could be another one that we could always do. We've got a few that different ones that could probably fit into there too. Oh, not that. Cool. Another one I saw in the chat that I do want to follow up on because it was mentioned in the text here was that we could do one for this patient. Let's write one for inadequate fiber intake. Okay. This is a true statement. Now, this patient, based on her diet, she has inadequate fiber intake related to few things. Could be the poor dentition, making it difficult to eat fruits and vegetables. And potentially it could be not choosing fiber foods. And then this would be as evidenced by dietary recall. Okay. So if I read that one out, it would be inadequate fiber intake related to poor dentition and not choosing high fiber foods, as evidenced by her dietary recalls. The dietary recall is what we're using to say, okay, this is where we found out that she's not eating very much high fiber foods. Good. All right. Yeah, I like that, Alexander. That sounds really good. Good. Okay, so there's two there that we kind of dropped in. I think there's a few more you could kind of stretch for, but those are two that I really like. Step three, what intervention would you recommend during this hospitalization? What about after she is discharged? So, what should be her diet while she is in the hospital right now with diverticulitis? If you are the RD, you look on her chart and it says regular diet, and you go, oh, I want to change that to something. What diet are you going to change it to while she's in the hospital? What do you think? Great. Start NPO. Yep, that sounds good. Clear liquids. All right, so let's say we're at like day 2 of clear liquids and she's hungry and she's ready to eat. What type of diet are you going to put her on? Is it going to be a high fiber diet or a low fiber diet while she's hospitalized? Yep. So we're going to do low fiber while she's hospitalized here. We're going to give her an education probably on how to eat a high fiber diet once she's discharged. And then once she's discharged, what do you all think should be her diet at home? What do we want her to start eating more of in her diet? What types of foods could she be eating more of in her diet? Well, once we go home, we're going to shift over to high fiber. Okay. So let's say her diverticulitis is done. There's no more inflammation, but she still has the diverticulosis. Well, now we're going to go over to a high fiber diet. Mhm. And I don't know if texture modifications are going to be too necessary for this diverticulosis necessarily. Yeah, for the poor dentition certainly, or we hook her up with some teeth probably. But in general, I just want her doing more fiber, especially to make sure that she is doing something about her GI tract here. Good. All right. Love it. And then what would you monitor and evaluate for the patient? Let's say you were seeing them an outpatient. Um, what would be some really, really simple things you think you would monitor and evaluate? Would it be signs? Would it be symptoms? Would it be anthropometrics? Would it be intake? What would you be looking at in that case? Hmm. Yep. Counsel on strategies. Yep. That's good. What I would monitor and what I would evaluate is firstly her intake, especially if I am using inadequate fiber intake as my PES statement. Guess what I'm going to monitor and evaluate? Her fiber intake. Make sure she's eating enough, right? Whether she's sticking to the diet, if she's doing fiber rich foods. Um, I could always check her anthropometrics to ensure that she is maintaining her weight if I was concerned about that. I could also ask her about her symptoms, just how she's doing with the diet itself, right? So, are you having constipation? Are you having diarrhea? Are you staying regular? Those types of things I can kind of talk to her about. Good. All right. Perfect. Okay. So, for sake of time, folks, we're going to move on to our next MNT section, clinical scenario. We'll go a little bit faster through some of these, but I just enjoy talking through these so much. It's hard not to go through everyone. Here is cirrhosis. Picked this one as a major player, especially because we know there can be a lot going into the nutrition of this. What cirrhosis is I would describe it as the end. It's the end of liver disease. You're going to die. That's what's going to happen. Damaged hepatocytes are replaced by fibrotic scar tissue, blocking flow of blood through the liver. After years and years of having chronic hepatitis C, chronic alcoholism, you've damaged your liver to the point where you are no longer going to be able to use it effectively. Okay. So that's going to be one big piece there. Really, I mean, the best thing you can do is cirrhosis. A lot of people will get a liver transplant. That's something that a lot of people will do. So, with the hepatitis and alcoholism, you've just really ruined your liver over the years. So, signs and symptoms of this is portal hypertension, hepatic encephalopathy, ascites, esophageal varices, fatigue, weakness, poor appetite, nausea, malaise, and jaundice is going to occur. For nutrition therapy, there's a lot we could kind of talk about here for a second. So, with the nutrition therapy, I want you to start by focusing on those calories. What do you notice right off the bat? 35 to 40 kcals per kilogram. Now, when we talked about Mrs. Stevens, we said she was going to get like what, 25 to 30, right? This is tremendously higher. And that's because cirrhosis is a very, very big disease. You're going to have a ton of inflammation in your body is going to be occurring. Okay. For the protein, 1.2 to 1.5 gram per kilogram is what the protein's going to be. And you could possibly even go higher if you needed to. Um, Definitely high in the protein. 1.5 I think would be a great number to pick for cirrhosis because yeah, it's just very, very severe. For vitamins and minerals, we're going to talk a little bit about their intake. Oops, sorry about that. There we go. Okay, that sometimes happens. With their intake here, one thing we want is we want them to be on a low sodium diet. Okay, so I'm going to add this here low sodium diet. I'm going to touch on why this is, But as always, when it comes to a low sodium diet, it has to do with the amount of fluid and pressure, osmotic pressure that is going on here. So we're going to want them on a low sodium diet in general. We want to make sure they get adequate amounts of vitamin D, vitamin A, vitamin K, zinc, selenium, B1, and B9. You can make, I'm sure, an argument for other vitamins and minerals, but per the text, this is what they mentioned. We think about adequate vitamin D because remember, the liver is involved with the activation of vitamin D, right? So maybe we would give them like vitamin D3 supplement because we know that without that liver being effective, they're probably not going to activate vitamin D very well. So vitamin D we know is going to be necessary because the liver is necessary for vitamin D. Vitamin A, much of that is stored in the liver. And so if the liver is impacted, we're going to need an ability to get vitamin A. So that would be good. The liver also contributes to coagulation in the body and coagulation factors, vitamin K being one of those. So, ensuring that we have adequate vitamin K is going to be a huge piece to that as well. Zinc, selenium, good minerals to ensure we have B1, B9. I think the B1 we always think of anyway when it comes to alcohol abuse, right? So this fits very well, I would say, to alcohol abuse, given that many people end up with cirrhosis as a result of alcohol abuse. Okay, now let's talk medications and labs. We're going to spend just about a couple extra minutes on this. When a patient has cirrhosis, a lot of the times, I'm going to draw out this patient here. Okay. A lot of the times, the patient kind of looks like this. Okay. All right. Bad drawing, I know. But they're happy. Good. So, a lot of the time, that cirrhosis will end up causing a lot of osmotic pressure, a lot of portal hypertension, and you just build up a lot of fluid and ascites, right? So that patient with cirrhosis will typically have a lot of extra weight on them, but it's not because they have extra body fat. I would say they just have extra fluid. So this is the ascites that is kind of occurring here with cirrhosis, right? So that being said, that ascites or presence of fluid is going to affect your labs. The labs are going to look wonky, in particular, a few of them, because of the ascites. Remember, it's like the concept of a glass of water or anything, right? If it's full of water and I only have a little bit of salt in there in this glass, right? One little flake of salt. Well, it doesn't taste very salty, right? So that would make my sodium look low, okay? Because it doesn't taste very salty. Now, let's say I drink this whole cup and then I fill the whole cup up with salt. Well, then I have a ton of salt, but I only have a little bit of water, right? So then my sodium looks high in that case. So take a look at these labs. We have a low albumin, and that's going to be secondary to the fluid, right? The albumin will look low. It looks low, but it's not actually low. It's the fact that it's surrounded by fluid from the water retention in the ascites. So albumin looks low, but it's not actually low. It's probably going to be the high amount of fluid surrounding it. Excuse me. We'll probably have a low prothrombin time, which is the amount of time it takes for us to clot. Because the liver is affected, you're not going to have those clotting factors. And so you're not going to be clotting very well. Actually, let's think of it the other way. I would say it's going to be a high prothrombin time, right? It's going to take us a long time to clot. And then we have our liver enzymes here, our AST, our ALT, and our ALP. These are all going to be elevated and high, which occurs with liver enzymes. They're all going to be high here. Okay, let's take a pause on that. What questions do people have right now just related to cirrhosis that we're looking at there? Okay. Yeah, good. Just a good little walkthrough there. Now, if we feel up to it, let's go through a patient here. This is going to be one where we're going to do a bit more interpretation of those labs that we have in front of us. Mr. F is a 45-year-old male. He has a past history of multiple hospitalizations secondary to alcohol abuse, alcoholic fatty liver. He is unhoused and mostly lives off eating processed meats, canned goods, sports drinks, and alcohol. He reports drinking up to 1 liter per day from vodka. Upon admission, he has ascites, portal hypertension, and severe emesis. Go ahead and take a second to look at those labs. All right. So with his weight, he's 165 pounds, height 5'6" labs of the albumin 2.5, hemoglobin of 9, and potassium 2.9. All right, let's start with these labs actually really quick first. Okay. So tell me, folks, albumin, high, low, normal. Hemoglobin, high, low, normal. Potassium, high, low, normal. Albumin of 2.5. Albumin of 2.5 would imply that is low, right? It's about what? 3.5 to 5.5 is about our normal. Okay. Hemoglobin, 9 grams per deciliter. This also feels low, right? I would say normal would be about 14 to 18. His potassium would be low, right? We know there's about 3 to 5 bananas on a bunch, so I always just go with about 3.0 to 5.0 for that there. You probably have a bit of a different number, but that's just what I stick with. Okay. Very good. All these labs are looking low to me. Let's talk about them just a little bit each while we're focusing on them here. His albumin, why is it low, everyone? Why is his albumin low? Let's read through what he's got going on. He has ascites, portal hypertension, and severe emesis. His albumin is low due to the fluid, okay, due to the ascites. That's what's causing that. His hemoglobin being low, that could be related to the cirrhosis, okay? That could be related to the cirrhosis. It could be just poor PO. Obviously, if he has iron deficiency anemia, that could certainly be causing that too. Potassium. The potassium is low and it could be due to the ascites. And then what I would also add here is that the potassium could be low due to his severe emesis, perhaps too. Let's say he's just been throwing up all of his normal sports drinks that he normally eats, drinks, throwing up all of those things there. So he's throwing up in that case. And so the potassium is going low. Good. Good. Yeah. A question from Alexander here. So, Alexander, good question on the erythropoietin. That could affect the hemoglobin. However, the decreased erythropoietin, I would not think of always for a liver patient. A lot of the times I think of it for kidney patients, though. That's what I usually think of for the need for erythropoietin a lot of the time, too. But it certainly could be, too. All right, so conduct your assessment of the patient's BMI if you would. I'm going to just walk through once again what I'm going to do there. We're going to take his weight first. 165 pounds divided by 2.2 is going to be equal to how many kilograms? That would be 75 kilograms. His height is 5'6", so that's going to be 66 inches times 2.54 centimeters. It's going to be equal to 168 centimeters, which would be 1.68 meters. And then finally, I'm going to take 75 divided by 1.68 squared. And his BMI got is like 26.6, 26.7, something like that. Okay. Yeah. And we also know he's had like a recent he's got this ascites going on too. So he's holding on to a bit of fluid. We don't know necessarily what his dry weight is. He could probably tell us, but I don't sense that he's the most reliable to do that, but he could be. Um, we could just kind of stick with what his current body weight is, though, in this case. 26.6 kilograms per meter squared. So, Emily, how would you factor the fluid into it? If you knew what his dry weight was, then we could always calculate his needs based on his dry weight. But here's the reality. Right now, if you look at his body mass index of the mass of what his body is making up, that's what you just calculated, fluid or not. When he walked in that day, this is what his BMI is, without a doubt. I know the fluid is on there, right? But this is how much he weighs. This is what his BMI is. So we see it all the times with a patient who'll come in with 20 pounds extra fluid and their BMI puts them close to obese, and then they can come in another time they're drier and they're overweight, right? It could just depend on it. But when he walked in that day, yeah, he's got an overweight BMI. For his energy needs, what I would prefer to do is if I could calculate his needs based on his dry weight, if he was a good historian, knew what his dry weight was, I could use that dry weight as that there. But for right now, folks, I mean, given the fact that he has cirrhosis, he has the ascites, we don't know how much fluid it is. I mean, I'm going to calculate his energy needs based on what his actual body weight is right now. Because I don't know if I can accurately determine what his typical body weight is. I think I can only go off of what his actual is at the moment. It's really the only data I have as I look at it. So I would say probably if I have his weight, which is going to be 75 kilograms, we know that it's going to be about 35 to 40 kcals per kilogram. Given the fact that he has extra fluid, let's just call it 35. And it says 26.25 for his calorie needs. Good. For his protein, I'm going to pick 1.5 grams per kilogram. So you would take your 75 times that, and you would end up with your total in that case. So if you took 75 times 1.5, I got 112.5 grams of protein per day. Yeah. So questions, chat, would you ever use ideal body weight with him? I mean, possibly you could do that if you wanted to. I mean, let's see what his ideal body weight would be. So his ideal body weight would be 142 pounds. So you could do that. It's 42. It's what, about a 23-pound difference or so between the two of those there. But for me, I'm just going to go with what he currently weighs right now. I don't know how much ascites he has. I don't know how long that's been. I'm going to go with what he actually weighs right now. Okay. All right. So create your PES statement for the patient. Start with your problem statement, folks. What would be your problem statement that you would pick here? I could think of a few that could fit pretty well. Think of the food that he's eating a little bit too could factor into this. Well, I think one easy one that I could go with for him, the fact that he has cirrhosis, easy one that I would pick for me would be increased energy expenditure. Okay, so I'll put an arrow and save some space. So let's do increased energy expenditure related to increased basal metabolic rate, or BMR, as evidenced by diagnosis of cirrhosis. That'd be one that I could use there. See a few more in the chat here that I think could also fit as well. So altered lab values, absolutely, Alexander. That'd be a great one we could use, as evidenced by low albumin, hemoglobin, potassium. What I really like about that is this is a great example because when you state a problem statement like altered lab values, your evidence, as evidenced by, has to connect to that problem statement. That's a good reminder for you all. You've heard it in my podcast that whatever your sign and symptom is, it needs to connect to that diagnosis. And a great example is altered lab value being your problem statement, your evidence being the lab value itself. It's a great one there. Yeah, love that there. Agree with you too, Emma. That's perfect. It's perfect. So let's do altered lab value. So one question in the chat about excessive, like excessive alcohol intake. Oh, it could be. Here's I think you could stretch it. Here's why I would say no to the alcohol, and here's my point here. When we talk about excessive or inadequate intake of something, we are talking about nutrients, okay? Oh wait, there is an excessive alcohol intake, isn't there? Yeah, under bioactive substances, there's a excessive alcohol intake. That's so funny. Okay, cool. So that one would fit as well. So you could have excessive alcohol intake related to diagnosis of alcoholism, as evidenced by patient reports 1 liter of vodka per day. What I was going to say was, I was like, intake should be related to nutrients, and alcohol is not necessarily a nutrient. Well, it does provide calories, so I guess you could argue it, but it's not an essential nutrient for sure, right? hmm Yeah. So a question in the chat here is if this PES statement would work. Um, Poor nutrition related knowledge. What I would call that is nutrition and knowledge related deficit. That's what I would say is nutrition and knowledge related deficit. Related to undesirable food choices, I would say it'd be related to lack of knowledge on types of foods to eat for cirrhosis, as evidenced by dietary recall. That would probably be my best fit in that case. Okay, so I'm just going to finish up this here related to cirrhosis, as evidenced by low hemoglobin, albumin, and potassium. Okay, great. The intervention that I would recommend during this hospitalization, folks, is I would recommend that this patient is going to be on a low sodium diet. Okay, so let's put them, or rather, let's just say sodium restriction. I'm going to want them to be on a high protein diet. So maybe give them a supplement if we feel like it's warranted. High protein, yeah, high kcal, sodium restriction. Mhm. Great. What I would monitor and evaluate for the patient is probably going to be their anthropometrics. Anthropometrics. I'll just say height and weight. Weight, um, their ascites present, so we can maybe get a better dry weight on them. Their PO intake, their sodium intake. That'd be all stuff I would monitor. Okay, great. Just want to leave an opportunity for any more questions about this clinical scenario before we move on to our last one of the night. Third scenario coming up here. A little bit less complex, though. Right. Okay. For our third disease state tonight, we're going to be going through gastroparesis. Gastroparesis will be another GI one that I thought would be good here. Okay. So for gastroparesis, I would start with by introducing that it is slow gastric emptying. Slow gastric emptying, gastroparesis. The etiology of gastroparesis is that it's usually a dysfunction of hormone, nervous, or muscular system. The meal macronutrient content is going to really affect is going to affect someone when they're eating with gastroparesis. And a lot of times people with diabetes also will be affected with gastroparesis as well. The signs and symptoms of gastroparesis are usually bloating, fullness, early satiety, and sometimes vomiting if it gets really, really bad. We're going to hone in a bit on the nutrition therapy and then we'll go through some medications. For the nutrition therapy here, the goal is it's very easy for kcal's protein and fluid, which is just to meet the needs. This patient is not really going to be in a high state of inflammation. Okay. The patient who has gastroparesis is not going to have a big increase in their basal metabolic rate, not going to have a big infection, not going to have a lot of inflammation. They just might not be able to eat as much as they normally do. So our focus is to meet kcal's, meet protein, and meet fluid needs. Vitamins and minerals, the fact is they can't eat as much intake. So we do want to make sure that they're getting plenty of iron, zinc, B12, and vitamin D. And a lot of this also speaks to the stomach itself. Gastroparesis is slow gastric emptying or slow stomach emptying. And so, sure, if I'm taking medications, maybe B12 is going to be affected. Maybe iron, with its love for acidic environments, also gets affected by it potentially too. Those would be some particular vitamins and minerals to focus on. Now, what do we avoid? We avoid anything that's slow digesting. Slow digesting foods are what we want to avoid at the utmost here. That would include things that are high in fat, high in fiber, and a lot of those raw fruits and vegetables, right? Anything that's going to really slow digestion or be like a big portion of any kind, we want to avoid here. Fats take a long time to digest. We know that fats stick with you for a long time, right? They're like a log in the fire. They take a long time to burn. Carbs are very quick to burn relatively. You can really break down carbs very fast. And if you eat just a carb rich meal, you know that it quickly exits through your stomach and you'll be hungry only an hour or so later. Fiber, we know that fiber is something that is a slow digester, right? It's going to take a long time for fiber to break down. We talk about those foods that are low on the glycemic index, for instance, that they don't cause big spikes in blood sugars. That's because it takes a long time to break them down. But if you have gastroparesis, this is bad. We don't want this to happen. So, for our medications here, I want to talk about a few. One is prokinetic agents, okay? Prokinetic. I want us to break down that word a little bit. Pro would mean promote. Kinetic would be movement, like kinesiology, for instance, is the study of movement. So prokinetic agents have the goal of speeding movement, and that movement is occurring in the stomach. Okay, so a prokinetic agent will increase the stomach or increase gastric emptying. Okay. Antiemetics or anti-nausea. On our last one, we talked about our patient who had a high amount of emesis, lots of vomiting, right? Well, a lot of the times, if the food doesn't move out of my stomach, people get sick. So, antiemetic agents prevent nausea, prevent vomiting, might help our PO a little bit or our appetite. And so, those would be also drugs that we could take here too, just to help them to keep their food down. For the labs, there was really nothing mentioned in the chat as far as the labs. Gastroparesis doesn't typically really affect your PO intake to the point where you're going to become malnourished. I don't think that's likely. There's usually like other comorbidities that are contributing to that. So I don't think you're going to end up with really, really low labs as a result or really, really high labs as a result, unless things got really, really, really bad, in which case, maybe. Okay. Let's do our last clinical scenario of the night for Zach here. So, Zach is a 33-year-old male who is referred to the dietitian for severe fullness immediately after ingesting meals. He reports that he experiences this sensation every day after dinner. His meal consists of a banana with yogurt at breakfast, a sandwich and chips for lunch, and ribeye steak, brown rice, and broccoli at dinner. I wish. He reports his largest meal of the day is his dinner. His appetite is good, but he feels unable to eat enough. He has unintentionally lost 10 pounds since being diagnosed. His weight is 210 pounds, his height is 6'2". Labs are BUN of 15, sodium of 140, hemoglobin of 15. Let's start with those labs and let's knock those out a little bit. The BUN of 15, folks, high, low, normal. How is that looking? Practice with me. BUN high, BUN low, BUN normal. What's that going to be there? I think this BUN is going to look pretty normal to me. Pretty normal BUN. Not too high, not too low. Pretty standard. What about the sodium? And what about the hemoglobin? Let me know what you got for all of those there. For the sodium, I know it's going to be what? Around like, 135 to 145? Is that the number that I like to pick usually? I think that seems good for me. So this sodium to me also appears pretty normal. So I think that's going to be okay. And then the hemoglobin, usually I use my rule of saying that men hit puberty between the ages of 14 and 18. So 14 to 18 is about my range for men. So I would say his hemoglobin is fine, maybe close to low, but he's fine. Okay, all normal labs, which means I don't have a lot to worry about there. for the BMI. Go ahead and calculate the BMI if you'd like to. I'm going to go ahead and I'm going to calculate on my own here, and I'll talk through it just for those of us that need extra practice on it. It couldn't hurt, right? 210 pounds, convert that to kilograms. The way I would do that is I would divide 210 pounds divided by 2.2 to end up getting the amount of pounds that I weigh, which is going to be 95 point, oh, I'm sorry, I said kilograms, 95.5 kilograms. Sorry to misspeak, everyone. Started 210 pounds divided by 2.2 to get 95.5 kilograms. For his height, he's 6'2", so that would be then 74 inches tall. 74 inches times 2.54 centimeters for every 1 inch. Would get me, whoops, sorry about that, 188 centimeters, which would be equal to 1.8 meters. Good. So 95.5 divided by 1.8 meters squared would get me a BMI of 29.47. I don't know, let's say 29.5. Maybe you got something close to 30 there, but he's pretty close, huh? Okay. Energy, kcals per kilogram. I want you all to think about this a little bit. Now, you could always use like Mifflin in an equation to calculate his needs. I'm fine with predictive equations like the numbers that we use, like 25, 20, 30, etc. But what would you feel for this patient? Does he need 35 kcals per kilogram per day? Probably not. It doesn't seem like he's having a lot of inflammation, right? So I don't really think that would be too good of a fit there. Does he even need 30 kcals per kilogram? With him being a bigger guy, I would say probably not. That even feels just a bit high when it would come to that. You know, for me, if I wanted to predict how many calories he probably needs to maintain his weight right now, I would say maybe I'm going to use 20 to 25? What do you all think about that? About 20 to 25 kcals per kilogram? That's what I would use. So that would get him to about 1910 to 2387, which I don't know, feels like a pretty good range for someone who doesn't have inflammation there. Yeah. Good. Good. The protein needs in this case, if we look at him, okay, is he, as we look at his needs, like, is he having severe inflammation? Not necessarily. I don't think he needs 1.5 grams per kilogram because he doesn't have wounds, trauma. He's not having severe inflammation, so that feels too high. 1.2 feels a little high. I think for me, I'd maybe put him somewhere between like 0.8 to 1.0 grams per kilogram. That'd probably be about what I would fit for him. Just in that case, maybe we pick the one just so we maintain his level of muscle mass being a larger person. And so I would just say maybe we have like 96 grams per day of protein, taking his 95.5 grams or kilograms of weight, multiply that by 1.0 grams per kilogram to get 96. Good. Seems like we're all in great agreement there. Now let's create a PES statement for this patient. Sometimes it feels like for these types of patients, it's actually just a little bit harder. But let's think of a little bit about what's going on in the question. He has unintentionally lost 10 pounds since being diagnosed. So within the clinical domain of the nutrition diagnosis manual, we do have something about weight loss, and we can say that he has had unintentional weight loss, right? Intentional. Let me just do that again. So let's say he has had unintentional weight loss related to fullness with meals. And I would say that's going to be as evidenced by 10 pounds of weight loss. Okay. Which is connecting directly to my problem statement. Unintentional weight loss related to fullness with meals, as evidenced by 10 pounds weight loss. It's fitting very well there. Good. Good, good. And then maybe one more we could always stretch out to. I don't think it's going to be a massive, oh, well, here's one that we could go with. We don't have an exact amount of how much calories he is eating. But the fact that he's had 10 pounds weight loss since having his diagnosis, he's having excessive fullness with his meals. Do all of you think maybe he is not eating enough to maintain his weight? Because I think that might be occurring. With him, I would maybe say predicted suboptimal energy intake or predicted suboptimal protein intake, either of which could fit. Let's say related to fullness with meals, as evidenced by, we can even say 10 pounds of weight loss. Good. Mhm. Okay. The question in the chat here was, would this qualify for malnutrition? We have no idea how much, how much he's lost in that amount of time. So yeah, I agree. We wouldn't be able to get much for the malnutrition in this piece here. Sorry about that, folks. Working on the tech. Come on, you. Okay, as that's loading up, what intervention would you recommend during this appointment? What would you go through with the patient? Well, to me, I would probably start by walking through a bit about the diet therapy. I'd probably really focus primarily on nutrition therapy and nutrition education for the patient, is what I would do. So I would do things like I would say, okay, let's focus on a low fiber diet education. Okay. Let's say avoid fluids at meals. We don't want to compete with the food there. Small, frequent meals. So let's say get our 4 to 6 in. Absolutely. Yeah, activity after eating, that would be perfect to do. A lot of those basic lifestyle factors that we would recommend doing there, right? What would you monitor and evaluate for the patient? Well, I think it's kind of said very well that we would look at his weight, his PO intake. Those would be a few things we're going to look into there. And then let's look at his reported signs and symptoms after eating. Okay. Is his gastroparesis improving at this point after he's eating these meals. Okay. All right. Okay, students. So hopefully you enjoyed going through those clinical scenarios. I really hope it did emphasize for a lot of you as to the reasons why we do what we do, what the big focus is, what's the points of the different diets and different therapies that we recommend a lot of the time. So hopefully you enjoyed that session. Hopefully you learned a lot. Remember to like this video if you haven't. Definitely helps out to just have other students see it. If you know of other students studying, hey, mention that we're doing these sessions. Tell them that they were fun. Tell them that you learned something, hopefully. Check out the podcast always. I want you kind of checking out those episodes as they come up. Not sure I'll get to one this weekend, just because I got a lot of family stuff going on, but hopefully we'll be back on the regular weekly track after that. I've been pretty good recently. And please come back to the lives, enjoy them, come watch them again if you want to. Go to the live section on YouTube, rewatch the old ones if you haven't, get a little practice in, and continue on your path. My biggest tip is to all of you is I always want you all to feel like you're welcome here. And as always, I'm always going to tell you, happy studying to you, RD to be. You can do this, and hopefully